Okay, so just to present myself, I have an interesting history. I trained as a radiographer, then a medical physicist and engineer, and I pretend I'm a health informatician. Actually, my health informatics interest came from imaging, where I was working on DICOM standardization for many, many years, and I was pushed to look at issues of how we deal with data and information in medicine. So this particular presentation is about how we make data and then we interpret it in terms of information, and then we create knowledge and make it interoperate from various heterogeneous sources of that information. So I'm here at the Institute of Digital Healthcare, and also hold an honorary appointment at Children's Hospital, where I do a lot of imaging work. So I'm going to use the Transform project, which is a large European project that has about 21 partners. Actually, we acquired one new partner today, which is a vendor. They come from 10 EU states, and we are funded for about 10 million euros to deliver an infrastructure that allows us to bring together primary care data for clinical research. So our main interest is to, wherever there is electronic healthcare records of some form and some structure, in particular we like the structured data, we try to link it, and then we look at issues of improving safety by creating alerts back to the clinical records, and of course conduct a large volume of clinical trials in Europe. Now, the whole challenge comes from this simple diagram. We have a lot of knowledge. We routinely collect knowledge, and we collect it in various approaches, paper-based approaches, but also electronic approaches. Of course, we have a wide coverage, varied quality. We might not have enough detail. I think Pete explained that even. That's the frustration we see in the NHS. From the point of view of primary care, we are lucky that EHRs tend to be more populated. Now, what we do is we do a lot of clinical trials, and in the case of primary care, we do a lot of primary care-based, community-based, epidemiological trials. We collect a lot of data. Now, where does this data go? At the end of the day, you as clinicians, I'm an engineer, but I understand that clinicians would like to use this knowledge and funnel it as an actionable knowledge so that you can give particular care. So Transform tries to integrate that type of knowledge by looking at problems of interoperability of data and information. So why we have the problem of interoperability? Well, as I said, we have a lot of data. If we include even genomic data, vast amount of data, multiple sources, but even within the primary care community in Europe, there is kind of disagreement in the dialect we speak. This data is 0, 0 and 1s as far as I'm concerned, but then it is knowledge or some kind of information, and everybody has a different dialect. In Europe they speak ICPC2, which is a particular dialect. Here in the UK we like to speak grid codes, and so on and so on. In some cases we write things in a narrative way. We speak the human dialect. And even there, we don't have a consensus on the terms and information we have. So that's a bit of an interesting problem, because it creates the Tower of Babel in informatics. So if we have all this data and information, it doesn't communicate, then in particular, in my interest, which is the cancer enterprise, it doesn't work very well. So if we want to integrate, and if we want to go towards the idea of stratified medicine and personalized medicine, we need to deal with this problem. And this is what we try to do. Now, terminologies are potentially the way you can deal with this problem. And I explained that usually we have the pragmatic approach. We use a dialect that we understand. Either it is based on natural language or some kind of structure. We have created a lot of terminologies that have associated coding systems and classification systems that allow us to express our particular domains in primary care, in disease classification, in cancer, there are different approaches. What is interesting is we can create what we call enterprise-level vocabulary services that try to pull together all these various terminologies and standards and make them work seamlessly. And this is what I'm going to try to explain today as a challenge in health informatics. That's very, very pertinent issue in health informatics, how we make a common language that is understood by humans, but more importantly, can be interpreted by machines, while humans don't need to understand the intricacies of that interpretation. So our challenge in Transform was to develop a user-understandable language or scheme that was computable, so computers can use it, and extendable, so that new knowledge could be created for capturing all clinical concepts and information for clinical trials. Because we do it in Europe, we want to do it not only in English, but in many languages. So somehow the French and the English or the Greek need to understand that user-understandable part. The computers need to understand it in a computable form. So this is where interoperability works. Most of the time when we talk about interoperability, even in the NHS, we talk about connectivity. Okay, and that's fine. We need to make devices to connect, and maybe we need to have some kind of syntax or messaging to make them exchange information. What is challenging is to talk about semantic interoperability, so that not only we connect the data, but the data has a meaning, and that meaning can be interpreted from both humans and computers. And for that, in Transform, what we have created, we pulled together all these dialects, and we created what we call an integrated vocabulary service that allows a user to put in human terms any kind of concept that might exist in medicine, and I'll come back to that, how we did that, and link it to any kind of dialect that humans and computers can have. So, of course, to do that, the vocabulary service has a lot of challenges. First of all, it has to be as complete as possible. Can we capture all concepts in medical knowledge if we want to do it without reinventing the wheel? And we did that by using a standard, one single organization of concepts based on the Unified Medical Language System, the UMLS, that is curated by the National Library of Medicine in the US. Of course, the vocabulary should have a fit for purpose, a particular utility. For us it was trials, but it could be used for recording information in consultations, for helping mining information in text, letters, in telephone consultations, in video consultations, etc. Wherever there are multiple languages, there should be a correspondence between the concepts and the different languages. It should give the same results across the domain. If I search a record of this electronic record here or in France with the same concept, I should get similar results. It should be valid for clinical use to produce evidence, and interoperable and sustainable. So these are the major things we had to do. So this is the techie bit. Okay. So what we have created simply is a service that uses a web service standard, so we can use it over the web. It has also a programmable interface so that you can see it on a website. This is the interesting bit. We use a standard technology that was developed by Mayo Clinic called LexCVS, and ourselves and Mayo Clinic has expanded this particular one so that we can connect all potential vocabularies in the field of medicine together by having a backend to the National Library of Medicine UMLS vocabulary, and then we use nice, interesting development tools to make it available, so you're not interested in that. So how does this work within an environment like Transform? In Transform we have a lot of tools for GPs and researchers to do clinical research in community trials and primary care trials. In particular, I would like to talk to you about the possibility to query electronic health records to identify eligible patients for trials, but also maybe if you find these cases, if you want to do epidemiological research, you could extract the data and collect this data in a form that you can analyze. So we do that through the semantic integration and using the vocabulary services. And I have a lot of nice screenshots to show you how this is happening. So this is the concept. The researcher sits in front of the screen, which is like a search engine, but it's a more structured search engine. It puts eligibility criteria like we do in any trial. It uses a particular way of understanding how data is organized in heterogeneous EHR systems, uses the vocabulary to identify the concepts, the human concepts he wants to put as criteria, and he throws it through a distributed infrastructure that connects a lot of EHR systems in a secure and integrated way. We also keep an auditing of all the actions done so that we have an integrity and security approach, and then it gets back results. These results could be counts or could be data, anything that is useful for the research. So this is how the whole workflow works. In terms of trials, we create a study, a protocol, we design the eligibility criteria, we get counts of patients anonymously, then we flag these patients anonymously, we send them to the EHRs, and then we can get data that correspond to these patients, let's say, for epidemiological research. Again, anonymously, all of this is useful. Or you can have the other scenario where instead of extracting data, you recruit these patients at the point of consultation. The GP gets a message which says, this patient is eligible for this trial, can you get consent? And then they are part of the trial approach. Now, these are the interesting screenshots. I'm going to go through these very quickly and because I want to show you the example of the eligibility. So this is how it looks like. We are in a workbench, people create new studies, and we have a specific use case for identifying prevalent cases of type 2 diabetes to do a phenotype-genotype linkage between the two. And then we create a specific protocol. I'm not going to go through that. There are different tools to do this protocol. But more importantly, you can get how many eligible patients could be available on your particular EHRs or repositories. And this is how we create eligibility criteria. What do? We identify criteria as potential groupings or archetypes, as we call them. For example, containers of criteria for demographics, diagnosis, etc. This is an example of diagnosis. Then you include this particular criterion by searching a particular category type of criteria, and then you select this type by searching this vocabulary service. So you search the term diabetes, and what you get from the vocabulary is potential terms that might be linked to the dialects we have in EHRs. This is the example of the vocabulary service on the web interface. So if I type 2 diabetes, what I get is all the concepts in UMLS. Here they are. Sorry, my animation. So this is what exists in UMLS, a full list of concepts. These are the formal concepts that exist in this language. Then I can see where they sit in the hierarchy as some sub-concepts or super-concepts for UMLS. Then I can see the definition of that. And this is what National Library of Medicine, this is the magical trick we have done. Well, we link this concept to all potential coding systems that exist in the world in different languages. So doing that, then this is what within our query workbench we get. We add the concept, then it becomes part of a set of criteria. An example where we can put temporal rules. For example, we can identify when people had particular levels of hemoglobin before or after particular periods, and then we can add quantities, and so on and so on. Then we submit the query to our databases here, for Transform, we do it with CPRD, which is a large secondary use database in the UK, and in Nivel in Holland. And what we get is the counts of eligible patients. So for different criteria, you can get individual counts, and then for the whole query, you can get how many prevalent cases you have. So in Nivel, for our complex use case, we have 1,400 people to recruit for this numerological study. Unfortunately, CPRD, we didn't get a lot, so maybe our criteria was interesting. Just to close, the concept behind all this is we understand how data is organized in various repositories. So the informatics work on interoperability is how to represent this data and use these tools. But as I showed for the clinician and the user, all of this is based on natural language. And this allows us to understand better and interoperate between the different concepts. Just very quickly to say, this is a very large project. I showed only a part of it. A lot of people across Europe working on this, and thanks to some of my colleagues who do all the good work. We'll just talk about it. And if you have any questions, I'll be happy to answer.